Sure. Can you hear me okay?
I can.
Great. Well, welcome everyone to the OneCare Learning Collaborative, Asthma and COPD. We're happy to have you join us today. Very excited about Sarah's presentation. Would ask everybody to please mute if you can, please. So today is Sarah Cosgrove from Rutland, who is going to be speaking to us about best practices in terms of tobacco screening and referral for efforts for tobacco cessation. She is a education coordinator for the community health team in the Rutland Regional Medical Center. She's a respiratory therapist and health coach and a master's certified tobacco treatment specialist and asthma educator. All of those skills are very important, obviously, for this group of participants in our collaborative. She has conducted training and provided mentoring for tobacco treatment specialists and asthma educators over the last 12 years. She's also the regional coordinator for tobacco cessation services in the Rutland Hospital Service area, where she does lots of interaction with multiple groups. She was trained at the University of Massachusetts in the tobacco treatment specialist program and also with the Department of Health here in Vermont. She developed the Vermont training for the American Cancer Society's Fresh Start Tobacco Cessation programs and has conducted multiple trainings around the state. The asthma educator role is also very important to her as part of the home visiting asthma program, providing individualized education to patients with asthma and underlying environmental triggers. As we all know, the home is so important for optimizing the home environment for improving the condition for both COPD and asthma. So the learning objectives for today are to recognize the incident rates of tobacco use in the U.S. and Vermont, and to do an overview of the 5 A's in tobacco use interventions. For those of you who are part of the collaborative, beginning at 1 o'clock, we will be having a half-hour session. There will be a short break there at the end of Sarah's presentation so that the collaborative participants can stay on the call between 1 and 1:30. Today's presentation is certified for 1 hour of category CME credit for physicians, nursing, and I believe pharmacists as well. And so, Tanya, if we could slip to the next slide. And great. So, Sarah, I'm going to give it over to you. Hopefully, we've solved the echo problem. And thank you so much for your presentation today.
Thank you. Can you all hear me? Hello? Uh-oh.
Yes, we can hear you. Yes.
Okay. Thank you.
Yes.
So thank you for the lovely introduction right there. And as you may have picked up, I've been doing this tobacco cessation work for a while, and I really want to impress upon you that if we work on these 5 A's, it just becomes natural with our interactions that we're having with our patients. So if you have any questions, someone will be monitoring the chat, and I will stick around till afterwards with the other group to just be able to answer those questions and be a resource for you. Next slide, please. So as you know, the tobacco use is the #1 cause of preventable death and disease here in the United States, and it's that preventable piece. This includes the risk to other tobacco users as well as the family members. We know that tobacco products are made up of thousands of chemicals, where, there's close to 300 that are known to be cancerous. So, I guess the bottom line is there is no safe level of tobacco use, even that secondhand exposure piece. Next slide. for a while here, smoking has been a huge risk factor for the other leading causes of death. And we know that in 2011, the incidence rate and reduction from death actually did reduce some due to the self-extinguishing cigarettes. But when we talk about the chemicals that are added to cigarettes for safety, which would be that self-extinguishing piece, that's a lot of chemicals that are being absorbed into the body. So, from beginning to end, tobacco use is a full body illness. Next slide, please. And we know that tobacco causes immediate changes to the body. The smoke alone can lead damages to the body, may cause medical symptoms such as shortness of breath, exacerbation of respiratory conditions, respiratory infections, as well as it contributes to heart disease, strokes, cancer, and other chronic respiratory diseases. So when we talk about tobacco use, it's a full body illness and symptoms that can occur from that. Next slide. So I was looking at your measures and data collection pieces, and one of them we're working on today is the percentage of patients 18 years old or older that are screened for tobacco use within the past 24 months. And these skills that I'm trying to impress upon you today should be used at every patient encounter. So if we just take away a little bit from today, you will definitely be able to meet those objectives and measures because you're learning to integrate it with every conversation that we have with patients. Next slide. So even a brief, and when I say brief, like 5 minutes extra, tobacco dependence treatment is effective, and it should be offered to everyone that is using a tobacco product. So when I say tobacco products, I am going to throw vaping right in there with it because the vaping of the nicotine is derived from tobacco plants. So it should be kind of lumped right in that same category. So the strategies for tobacco cessation and tobacco dependence is a chronic health condition that requires multiple interventions by like a clinician, a team of clinicians, and the health system involved. The 5 A's, which is we're going over today, which is the ask, advise, assess, assist, and arrange model, is a useful way to understand and address tobacco use dependence and treatment in an organized manner to implement an intervention. Although a single clinician can provide all 5 of the A's, if it is divided up amongst a team and looked at as a team approach, that's really where the patients start buying in. We know that people need to hear the message multiple times before it clicks in their head, hey, I got to quit smoking. So how do we start that ball rolling? And another piece of it, not only doing the 5 A's in the clinic, the clinician treatment extends outside to being able to direct people to resources. So knowing your tobacco cessation quit lines, your web-based cessation interventions, and as well as some in-clinic and local cessation programs can be very easily incorporated into that 5 A's approach. And it streamlines the process. People get very intimidated when they think they have to have that in-depth conversation about tobacco use, and they don't want to turn their patients off or make their patients angry. So, this is the fine-tuning piece of it, to have that conversation and know that we're hitting those points along the way that leads to that patient's success and really moves their motivation towards wanting to quit. Next slide, please. So, this was a visual that was on the 802 Quit website prior. I couldn't find it this time around. They've modified it a bit to reflect a quicker interaction approach, but I'm going to focus on the 5 A's because that's what I was trained on. And once you get these skills, it moves along much quicker. So I'm going to actually send the PDF to Emily, too, to be able to share this because in our clinics and in some of the practices that we have here in Rutland, they actually have this stuck in the clinician station or is on a clipboard. So it's like almost a cheat sheet to follow back, make sure that we're hitting those points along the way. Next slide. So, who, when, and where? Tobacco cessation is a basic healthcare service that should be provided in all healthcare facilities. So, all doctors, dentists, primary care specialists, integrating this into the regular routine care makes it easier on us because we start understanding it. But then we know that these patients are hearing the same consistent message again and again. So whether it's coming from the nurses, backed up by the respiratory therapists, the medical assistants are on board, the care managers, they're all saying the same consistent message and using similar tools. And this protocol can be used in any healthcare facility that's really working with patients. Next slide. So we model behavior for the community and for our patients. And we serve as those tobacco-free role models for the general public. And as part of that, we're going out there, we're, promoting health, and it's part of our responsibility to address tobacco dependence as part of our standard practice. And to include secondhand exposure, to be able to ask those questions, is anyone smoking around you? Because as once again, that secondhand exposure needs to be noted. We're providing resources to those people as well, but, where are you recording this information? And also paying attention. I know we have a practice around here, and I was driving through one of our fast food restaurants, and behind the clinic, there were 3 nurses out there smoking. And just the message it sends, so we want to be the ones promoting that tobacco-free message out there. And if there's still smoking places where staff's going out to smoke, to make sure that that's not right out there, because we know that patients definitely see that, and they're looking towards this as the health model for them. Next slide. I include this slide in here because as part of my counseling, I can say the same message to someone 100 times, but I could script it for their doctor to write a note. The same exact thing I've said, and that the patients will hang on to that and be like, my doctor said. It could be the same exact thing I've said to them 100 times, but that healthcare provider, it is going to weigh much heavier than it is me, the respiratory therapist or tobacco treatment specialist. And it's almost, I kind of want to say, like a disservice if we don't provide that information, because they trust our words. So from my experience, if that physician or primary care provider has a relationship with that patient, that advice of the physician or the provider is very, very strong. And by the weight that is held by those primary care providers, you have the potential to reach every patient you're working with. But there's a higher trigger rate to actually initiate a quit when the doctor or the primary care has that conversation with the patient. So there's a lot to be said about just saying it, and realizing that it may bore us saying it again and again, but it takes up to 14 times of hearing the same message before something just clicks in that patient's head where they're like, I am ready. We've motivated them through the stages of change to that point that they are ready to make that change. Next slide. And it's important to realize that we all play a role. Everyone from when the patients first step through the door, every contact they have along the way to when they're leaving again. There used to be like that old marketing adage that it takes 7 times that someone has to hear the message before they can really make a change. Well, I'd say that's more like 14 times. The first time someone, they don't hear the message, you really should quit. Have you thought about quitting? The second time, they notice it. They start paying attention. Third time, they become aware. Each time, they're gathering a little bit more momentum. And that's where it's our job to keep it going, to everyone to be saying that message and being able to, I shouldn't be reading the chat thing. Being able to, everyone being comfortable to have that conversation. And it's everyone, because when you do that, if you were not having that conversation, you were just to write out a referral and send it out to the quit line or send it out to a tobacco treatment treatment specialist at one of the hospitals, the exchange rate on them actually, returning that referral is, in my case, less than 3%. When the doctor has the conversation or the physician has the conversation, and then that patient comes to me, their motivation is much, much higher to quit than just, a cold call referral. So it's us having all a piece of it, having that same conversation. And don't confuse your boredom with having the conversation again and again with theirs, because I don't want to say they're not paying as much attention, but they're hearing it much less than we're hearing it, I guess. So keep it going. Everyone send the message, and we're supporting them along the way, as well as letting them know, hey, this is where you come back for help. Next slide, please. So 802 quits. 802quits.org. This is a fantastic resource here, and there's actually a provider section. And I advise you to go and check out this website because there is valuable information here. But this is also a resource to send back to our patients, too. So as well, the resources that they have available, wanted me to remind you that 802quits.org offers translation services for non-English speakers. So the resources they're trying to gather right here meets our whole population. Like, we can find a way to meet the needs of our patients and help them with cessation with this resource here. So I advise you all to just check it out, play on it, but definitely check out that providers section. There's some good information there. Next slide, please. All right, so with practice, this can, believe it or not, the 5A's model can be a 5-minute intervention. Brief intervention for tobacco cessation is a set of very basic methods that can be used by healthcare professionals during their routine clinical practice, as well as basic communication and having it take minimal time. It does not require any additional counseling skills whatsoever. And this is a simple tool just to start the conversation to talk about tobacco use and secondhand exposure. Most clinical guidelines endorse this 5A's framework as a useful strategy to engage patients in discussion about smoking cessation, tobacco cessation. And we're going to take a little time to go over each of the A's from that patient perspective by, highlighting some of the skills that we might have to build up in you along the way to get you to have that conversation. Can you guys hear me?
Yes,
Yes.
Sarah.
Yes.
Okay. All right. So next slide, please. So our first A is ask. We are going to ask about tobacco use at every visit. And you're integrating it into your vitals. So ask about tobacco use every visit and implement that system in your clinic that ensures tobacco status is obtained and recorded in every visit. So why would we ask every visit? Well, you have a person that quit smoking and they've got their 6-month checkup. You have them documented as quit smoking. Well, they've relapsed through that time. They're coming back to you. This is that time that you can jump back in, provide them resources, and get them back on the wagon towards quitting. So asking each time, it may change. And that's with people that are struggling with quitting smoking, it does change. They go through several attempts. To also let the patient know that this question is going to be part of the process and they're going to be asked every time. And just being able to clarify that piece to them, I'm going to ask you every time, so don't worry about it. You'll get used to it. And, making sure that you ask about e-cigarette and vaping in addition to cigarettes and chew tobacco. And it's knowing your population, because if you were to ask a teen too, hey, do you use an e-cigarette? They may not say yes, but do you use a Juul? Do you vape? And it's the wording to use along the way, because I do work with youth, and unless I, ask them if they flat out Juul, they'll be like, they will not answer me as I think they should. So being sure to ask, do you use any tobacco products, cigarettes, cigars, chew, or do you vape? Followed up by the question, does anyone in your household use tobacco products or vape? And being specific is very important. So some of the questions that might be a good follow-up to that to kind of keep it rolling along the way and feel like it's a good part of the conversation. So tell me about your smoking. How did you start? How old were you? What purpose does smoking play in your life? How much do you smoke? And honestly, for quite a few years, I had the cheat sheet of questions I would ask like this, my open-ended questions, so I can dig more into the conversation. Motivational interviewing is a fantastic skill to have, and if you are offered the training, I would jump on it. So what are some other questions you can ask? Tell me about your past quit attempts. How many times have you tried to quit? What was your longest quit attempt? What helped you stay tobacco-free? What caused your relapse? So using those open-ended questions, too, definitely pulls more information out of them. And you will get some people that really don't want to have that conversation, so by keeping it open, kind of keeps it rolling along the way. And it really is a misconception to think that your patients are going to get annoyed by you asking, or you'll embarrass them. Let's be honest, we are providing a service to them, and it would be a disservice to not ask these questions and be able to provide them and not provide them resources, because we know it contributes to a whole body illness. Next slide, please. So vital signs. As I said, being able to throw this conversation right into the vital signs. So having medical assistants feel comfortable being able to ask these questions. So some of the ways I've seen people ask these questions is flat out, do you or does someone in your household ever smoke or use nicotine such as e-cigarettes or vaping? Well, that would be a closed-ended yes or no. So being able to ask which kinds and how frequent is a follow-up question. Or, you're a very polite person. Do you mind me asking? Being able to ask that permission and say, do you or anyone else in your household smoke? And many clinicians or people doing work with patients, it's that asking piece that opens up that greater conversation. Some other questions you can ask, what type of tobacco products do you use and have check boxes for them to check off? How frequently do you use those products? How many other tobacco users live with you? And are you exposed to secondhand smoke throughout the day on a regular basis? Being able to capture this information definitely helps us, start connecting people to resources, but is valuable conversational information that you can definitely, plug away and meet 100% of your patients by screening them for tobacco use. So next slide. This is where I get people that are really uncomfortable in the physician's offices, and they're like, how do you even have that question or ask that question? I'm really uncomfortable asking that. Well, I always say, if I have anyone say, why are you asking? Well, I'm a respiratory therapist, but because I care about my patients, and I honestly think it'd be a disservice if I didn't ask you that question and try to give you some help. Or being able to tie it into their medications they're using, because we do know that tobacco smoke actually blocks intake of many medications. So saying, this medication that you're using to treat your heart condition, does not work properly when you're smoking cigarettes, or is known to interact with your tobacco smoke. Being able to give them, to tie it directly into their health and their situation. Your COPD is exacerbated or made worse by your smoking. Quitting will greatly improve your chances of it not getting worse. Just these little tricks along the way, and, it might almost seem like having a canned phrase while you're starting out may help you. But these are some great things. And to be honest, I don't think as many people question you asking, because it's becoming part of, the process. And they're asked these questions in multiple other places through screening processes. So I guess my bottom line is just ask the questions. And if they question it, because I care. Because we do. That's why we're all in this. Next slide, please. And that's going to be one of our most important things. Advise tobacco users to quit. So using your clear, strong voice, personalized manner, tie it into the conditions. Quitting is the most important thing you can do to protect your health. And we can help you. It's important that you quit smoking using tobacco products. Even occasional light smoking is dangerous. Do you want to talk to someone about getting some help? Continuing to smoke makes your asthma worse, and quitting may improve your health. You know, just these little tying it into the medical conditions. Quitting smoking may reduce the number of ear infections that your child has this winter. How do we tie it into what's going on? And, you know, saying to them and understanding that this is a difficult process. So quitting all tobacco use is one of the most important things you can do for your health. I understand quitting can be difficult. We're here to support you, and we have resources to help you. Can I provide some of that to you? Maybe they're not ready right now, and they say no. Well, guess what? Next time they come around, we're still screening every time. They're going to hit them up, and eventually, you know, they're going to hear this message, and it's going to click with them, and they will recognize you as that support to help them quit, or where to go get that support to help them quit. Next slide. And these are just some examples right here that I give you as well. Next slide. Does anyone want to try practice advising someone based on this situation? No? Okay. Well, a good example. Okay, I like the 16-year-old male that's an athlete. They have exercise-induced asthma. You know, they've admitted to vaping Juuls 3 to 4 times a week, and they're having increased shortness of breath. So, you know, we've screened. We've got this information from them. Now, excuse me, I'm going to lose my voice. Now we're going to advise them. Well, you know, Johnny, I'm going to do this off the swing right now. So your asthma is acting up. You're having a little bit more difficulty breathing this year, and I see that you are juuling. You know, we know that juuling and vaping definitely contributes to shortness of breath, and it's not a safe alternative to smoking. And if you're not using those vaping products, you won't need to use your inhaler as much. Can we talk about your tobacco use and your vaping and, you know, connect you with some resources? What do you think of that? You know, that was that advising piece and moving on. Being able to tie in, you know, the 2-year-old with RSV history, frequent ear infections, being able to tie that condition in of the ear infections with mom quitting smoking. And, you know, mom may say, well, I smoke outside. Well, you know, we know that some of it's still carried in on our clothes and stuff. Do you want some resources to help you? I can connect you with people to help you. No, I'm here for you. Just to be able to throw that out, you're tying it into the conditions, and you're bringing them back to you. I don't know if I'm nervous or what, but it just got like 110 degrees in this office. Next slide. So, assessing readiness to quit. And I think this is where I realize there's a disconnect from what we think versus the patient. So don't assume because of someone's medical condition, mental health history, that they are not wanting to quit at this time. Do not assume. Ask every tobacco user if they are willing to quit. And if they are willing to quit, yes. Let's talk about resources and assistance. How can we get you ready and get something in your hands right now? Because that is that teachable moment. If they say that they're thinking about it, let's hit the iron when it's hot, okay? If they are unwilling to quit at this time, you just point out some of the things they've got going for them that could improve through, taking tobacco and vaping out of the equation in a very supportive manner. We build up their confidence, You can do this. You've done it before, but know that we're here to help you, okay? And being able to say, come on back to me, and we'll find those resources for you. And for former tobacco users, it's really important to find out how recently they quit, and if they're having challenges along the way, because if we can help them during that quitting process or to remove some of those barriers along the way and get them help, like nicotine replacement to make it easier, we want to be able to do that in the moment. As you realize that hand off to someone else, we lose a lot of patients. So if we can take care of it right there in the moment, it is more successful, I find. Next slide, please. So how do you assess the readiness to quit? And these are all some of my tricks that I use along the way. Anyone who knows me knows I have really no shame asking any questions whatsoever. And that's part of it, is being comfortable in yourself and being able to ask these questions. Have you ever tried to quit or thought about quitting? Tell me about that. How did it go for you? I always like to add, when I ask the close-ended questions that end with yes or no, tell me more about that. It's amazing how much you can reel out of people there. What did your previous quit attempts look like? What worked for you? What didn't? What do you think you need for help? And how can I help you? Another one is, when do you think you want to try quitting? We're assessing where they are in that moment, and if they're like, talk to me next time, guess what? It's going to happen anyways because it becomes part of our regular process. So I guess what I want to impress upon you too is, don't assume your patients don't want to quit, because we want to plant that seed and start the motivation along. And I've seen many people that, honestly, I didn't even think, I personally didn't see it moving on to a quit attempt, and they've jumped on board, and just from me planting that seed and trying to pull more out of them, and we've seen them progress right through to being a quitter and maintaining that quit. So feel these questions, get comfortable with them, because it does come together and it starts being natural in your interactions with your patient to just throw that tobacco piece in there. Next slide. Assist. So how are we going to assist those that want to quit smoking? And would making a plan here be helpful to you? That way you'll know the plan and we can help you prepare. Being able to say to them too, hey, you know that there's free counseling here available. There's virtual groups right now going on that are very, very helpful. Or, have you ever tried giving 1-800-QUIT-NOW a call? Know those resources out there. Right now, given COVID, there's not as many or if any in-person services available. As COVID moves along, and hopefully that we'll be able to have something built in place that in-person tobacco counseling will be available, or being able to train someone on your staff to give that deeper level of tobacco treatment specialist and that touch that they need. When we talk about quitting too, we always say when you're working with someone to really have them pick a quit date to strive towards that's within 2 weeks of the day you are now. If we shoot out too far, you lose momentum along the way. 2 weeks gives people time to start preparing and really start thinking of it along the way. Another tip we tell people, is to tell your families and friends as well as coworkers to add that accountability piece to you, especially if they're the people that are smoking around you. You want to get that word out there. And then, how do we anticipate or plan for the challenges during those first few weeks? And that's, hey, so you've tried to quit before. Where'd you slip up? Where'd you have those hard times? Think about that. What went right and what went wrong? Start thinking about it. That's what we say to them. And then to advise them to remove the tobacco products from the environment. if they are there, the cigarettes are there in the home, it's going to be that extra temptation. Like having a chocolate cake sitting right in your refrigerator. Every time you open it, it's sitting right there if you're on a diet. You know, you don't want to do that. So being able to get the tobacco products out of the house are very important. Now, some people that adds a little bit of anxiety. So we say, well, you know, let's get it out of the house, stick it in the trunk of the car, or you have to go, you know, take the walk out to the car to think about it. Or, you know, wrap a bunch of rubber bands around, make it as difficult to get to as possible. I was working with one patient who had a lot of anxiety when we'd say, let's get the tobacco products out of the home, and that would scare her. What if was the thoughts in her head. So we actually took a bag, a plastic bag, put her cigarettes in one plastic Ziploc bag, then put them in another plastic bag and filled that with water. And then she froze the two plastic bags. So no matter what, the cigarettes were there, but it was difficult for her to get to it. And it actually made her feel more comfortable without that anxiety piece going through the process. So just to have the conversation about removing the tobacco products and offering some advice, what do you want to say? But to be able to provide them with 802 Quit resources in their hand, and if there's local workshops going on, being able to provide that to them. Know your resources, put it in their hands. Fax referrals, do it on the spot to 1-800-QUIT-NOW, or a referral directly to your community health centers or community health teams that are working with tobacco at this time. Being able to put that in their hands is very important in that moment. So you can call and reach out to the 802quit.org and get pamphlets for your office. Have that on hand so you can physically put something in your patient's hands with the resources available. Next slide, please. And another piece of assisting is the nicotine replacement piece. And yes, they are over-the-counter products, but us being able to have that conversation is very important. So the FDA-approved medications are the short-acting nicotine gum, lozenge, inhaler, and nicotine spray. So those actually get in your body fairly fast, and they provide relief instead of that cigarette. You have the long-acting products, the nicotine patch, and then also we see the nicotine patch combined with Wellbutrin to really help through the process. So those, the long-acting and the short-acting, with the exception of the Wellbutrin, are over-the-counter products. Then we have the prescription medications that are used, which is Wellbutrin and the Chantix. Being aware of how to use those nicotine replacement properly is very important. So with nicotine replacement, it actually reduces the withdrawal symptoms along the way that help patients succeed in quitting. A way I like to describe it is like a Band-Aid. We're going to put this Band-Aid on you for the nicotine replacement so you feel more comfortable while you're going through the process to make these changes. And the sooner people start trying the nicotine replacement and start seeing success, the more they're going to tack on to it and really keep using it. So the nicotine gum, using it properly is very important to its success. You really chew it like 7 chews, and then you stick it in your cheek. The continuous chewing of the gum really makes your stomach sick and doesn't do anything for the cravings. But if you chew 7 times, you feel like they call it peppery taste in the back of your throat, but it's almost kind of gaggy. And you tuck it in your cheek, it's along the lining of your gum line there, it's that touching of the mucosal lining in your mouth that the nicotine is actually absorbed in. And the majority of people I work with, much like inhalers, you have to have them say, please, the teach back, please show me how you're using this. Nicotine lozenge. It sounds like you should be sucking on it like a cough drop. You don't. You tuck it in your cheek and you let it dissolve. So people using these products properly leads to the success of it. And being able to have those teach back moments, show me how you use your patch, show me how you use your gum, is important because it's that fine tuning piece. And I've been counseling for a while, and I can tell you that I do that teach back every time I had a class. How are you using it? Because, people have a lot of things going on in how they think they heard the directions versus how they use it is maybe different, and we want to have them be successful. So you yourself knowing how to use these products and recommending them is very important. Next slide, please. So as I said, these are over-the-counter products, and not everyone can afford the over-the-counter prices. It can get quite expensive over time. So to know that 802-QUIT, the phone counseling service, 1-800-QUIT-NOW, that they actually provide free nicotine replacement. And that is very, very beneficial to someone in a quit. It also links them with a counselor, and we know that counseling and nicotine replacement doubles their success rate. So they can purchase these products over the counter at the pharmacies. They can call 1-800-QUIT-NOW. 802-QUITS.org sometimes has information about obtaining nicotine replacement through the website. And then being aware that some insurances do cover nicotine replacement with a prescription. So Medicaid, Blue Cross Blue Shield, and some Cigna packages cover nicotine replacement products, the patch gum lozenges, with a prescription that providers would be writing at low or no co-payments. And that definitely makes a difference with a quit for a lot of people. So I highly, emphasize learning about nicotine replacement. And if you have someone that has expressed interest in quitting, start planting that seed. Hey, would you be interested in a prescription for patches? Would you be interested in getting some nicotine gum or lozenge to help you? It'll make the process much easier. Next slide, please. Oh, I got way ahead of myself here. So I know, Dana, you're on the call here too. So we know with a prescription, Medicaid covers nicotine replacement up to 16 weeks, while Blue Cross Blue Shield, last time I checked, covered 8 weeks of patches. If someone were to reach out to 802-QUITS, 1-800-QUIT-NOW, they could get 8 weeks worth of nicotine patches and gum, or 16 weeks of per year of patches or gum alone. That is a huge cost savings. And right now, because there's no groups going on in person, at that time we're still working through what that's going to look like moving forward. But prior to COVID, people participating in the in-person groups in the hospital service areas could get 8 weeks worth of nicotine replacement. So free nicotine replacement is hard to come by, guys, and I really honestly suggest, use that prescription to get it in their hands sooner than later, and to send people to the quit line to get that nicotine replacement too. Next slide. So provide that practical counseling, include problem solving or skills, and make abstinence a goal. So not even one puff after the quit day, that's really the goal, because it's enough to just keep those receptors awake and wanting more nicotine. One puff's too much, 1,000's never enough. And to people working with multiple addiction issues going on, they understand that. That makes sense to them, because we know that one puff of that cigarette is just that temptation for more to come. And emphasizing to them, we're here to help you. You can do this, That one puff in the morning, you can do without it, okay? How do we make that happen? And it may be, adjusting their nicotine replacement levels so they're more comfortable. Review past quit experience. Well, Mr. Jones, I saw you quit 10 years ago for, the past 10 years. What went well there? Where'd you slip up? What was going on? Quitting is like a stair process. Every time that you accomplish and succeed, it brings you to that next level. So being able to get through without smoking in the car, if that's a difficult area, that bumps them up that next level. They have a little bit more confidence that they can get through that situation. And they keep building up the stairs. Now, here's the thing. Past quit attempts are very, very valuable information. They help people realize what they were doing right and what works, and they realize, trouble areas. So being able to ask those questions, where did you slip up? And they may say, it's talking on the phone with my sister. Okay, what can you do different instead of picking up a cigarette? And you're kind of trying to pull from them what they can do different in that situation. And then, tying on to any other experience that they have from other addictions or their loved ones, understanding, this is a nicotine addiction, not just a dirty habit. And we start shifting it away from it's a dirty habit versus it's an addiction, and big tobacco has targeted populations for decades. It takes some of that shame off themselves, and they start looking at it like, yeah, I was duped into smoking, and look what it's done to my body. And it does happen, honestly. And it's that progression. It's having the same conversation again and again and again, because eventually it clicks. Next slide. So in thinking about this, working with them to identify challenges or triggers on this next quit attempt, or how they can overcome them. Stress that positive self-talk. I think I can. No, you can. You can do this. Having them talk. I have them talk to that cigarette while they're starting to quit in the beginning. Do I really need you? You can't will you fix this situation? And the answer is usually no. So being able to get them to talk themselves through it. I can do this without the cigarette. I can do this. And I've had clients that actually out loud talk to themselves through the situation. Or they're having a cigarette craving. They'll go, trigger, what's triggering me? To try to work through the process of what is it that's making me want that cigarette so much. We always say, have the alcohol conversation with them as well, because we know that alcohol and cigarettes run hand in hand. And if you're drinking, you get loosey-goosey. You don't really think about that quit attempt, and falling into those old patterns of a cigarette and booze definitely, makes that quit attempt harder. So being able to recognize that maybe you don't want to be smoking, or you don't want to be going out drinking, or, going to bars while you're trying to quit, because that trigger will be right in your face. Engaging other smokers in the household. Quitting is more difficult when there's another smoker in the household. And when someone in the household quits, other people follow suit too, because they're learning along the process. But, it's always easier to watch someone else go through it and then jump on the wagon afterwards. So to have that conversation with loved ones too, other smokers in the house, let's identify them, and, let's give you those resources to go home with as well. And, having that conversation, that I'm trying to quit, how do you enforce it in our patients, to say, hey, trying to quit smoking, and to not have people smoke in the presence, whether it's in home or in vehicles. And, I have people practice saying that to me. How would you tell your sister to not smoke in your vehicle with you? Pretend I'm your sister. So how do we have that conversation? Or how does the loved one start the conversation with, say, their husband? And that's, who's smoking. And that's the planting the seed. Because anytime you tell someone they need to do something, like a loved one, you need to quit smoking because of that I have COPD, it's more difficult. Let's put the resources in their hands and just say, any cigarette smoke that I breathe in, whether it's firsthand or secondhand, will make my COPD worse. I can't have people smoking around me. Can you smoke outside? Or can we assign a certain section of the house to smoking? And that's kind of harboring off the areas where people can smoke and making their smoke-free zones safe zones for those people that are experiencing health concerns or trying to quit. That is one of the hardest conversations when one person in the household's quitting and there's other people that are smoking. and I mean, I don't want to say misery loves company, but they do try to, I don't want to say sabotage, but sometimes they can be a barrier to people quitting. So recognizing that that person in your household that's smoking may not be the best support person for you through this process. So how do you identify positive sources of support while you're trying to quit, while still planting that seed for those ones around you that continue to smoke? Having those resources and understanding what's out there to help you quit is a huge piece. Next slide. It is hot in this office. I don't know if the sun is just hitting me just right. Know your resources, honestly. Be aware of what resources are out there and supplemental counseling. So have the information on tobacco cessation right there. Have your 802 quit flyers and your pamphlets out there. Research yourself, 802quits.org, and look at that physician section of it for handouts and just, there's tips on having the conversation. And then really be aware and be in contact with your local sources. I know we're going through a transition right now with the blueprint self-management programs and tobacco cessation moving forward. So be aware of what resources are there. If you go to myhealthyvt.org, there's virtual classes that are listed that are running throughout, that are running monthly. Be aware of those resources. Have those classes, a list of them printed out. Know who your regional coordinator is, too, that's working with tobacco cessation so they can keep you abreast of what resources are out there and what the in-person model for your hospital service area looks like. And also consider having someone trained on staff as that tobacco treatment contact person that could give a little bit more time to these patients, but also for the greater staff could help educate them on nicotine replacement. That could keep those resources up to date, and could do this education for other staff members. So I'm a huge advocate of having someone trained on staff, but using this 5A's model, you don't have to have any special training to just be able to have these conversation pieces. And having flyers. I don't know how it's working these days. I'm imagining everything's laminated, and the less flyers in the rooms, the better. But being able just to have those resources there and not hesitate putting them in the patient's hands. Next slide, please. And that's our 802 quit resources. There's the quit by phone piece of it, the quit in person, which would be your regional coordinator local pieces, and then the 802quits.org. Amazing resources that they have available. And if you reach out to them, you can have these resources sent to you so you can have them right there. Flyers, I mean, the visuals are beautiful. The information is fantastic. And they've got several different, they've got one specific for pregnancy. I've seen them tobacco and asthma, ones that just list all the resources. I would definitely have these on hand. Next slide. And what we do right now have regional coordinators in each hospital service handling tobacco cessation. I think you really have to think moving forward. While that blueprint funding, from what I understand, is not necessarily moving forward supporting tobacco cessation in each community after January, how do we have the resources in the community to provide face-to-face for those clients and those tobacco users that don't have access to computers or do not communicate well through cell phones or phones? How do we still have a population out there that needs that face-to-face? We have to think of creatively as a community and state, how do we meet those needs? Because moving forward, none of us are sure if tobacco, in the form it is in each hospital service area, will continue to look as it does. Next slide. So I advise you to check out these classes too. So myhealthavt.org, that has the virtual tobacco cessation classes that are going on with some amazing tobacco treatment specialists here throughout the state. I don't just say that because I participated in their training, but I know this empathetic, great group of people that are out there offering these virtual classes. And, you know, the groups still form. I mean, the dynamics still happen within these virtual settings that they're getting from the groups. But there's also the options for diabetes prevention classes in the virtual forum, diabetes, self-management, chronic conditions, and chronic pain workshops as well that are put on this platform. And you could see the dates in the schedule through myhealthavt.org. So I definitely think you should be familiarized with these resources right now too. Next slide. And this is an example of the time I just clicked some of the classes just to show you that there are multiple ones happening. And despite, you know, Brattleboro may be the host, it's available statewide. So someone in Rutland could be taking class, someone from Chittenden, and it becomes a nice little mix of people, all with the same underlying goal to quit smoking. So bringing everyone together also builds up that confidence. And right now, being the virtual setting, it's really the only way that we can do groups at this time. Next slide, please. And motivating to quit. You know, to be able to, does that mean? To be able to motivate someone to quit is just to have that message again. To be able to say, hey, you know, I feel strongly about tobacco use and its effects on your health, and I will ask you again next time I see you. And realizing that, you know, our motivational messages here that we're sending them that directly relates to their disease status, their risk, health concerns, or their family situation. I think, go back right there. You is important, you know, to pull out, you know, the characteristics, having children in the home, caring for an ill family member, your own personal health. Those are motivators to get someone to really start thinking that next step for a quit. And then risk, highlighting the negative consequences of smoking. Now, we know they know it, but being able to connect those pieces. It interacts with your medication. You actually need more of your medication because you continue to smoke. You'll have less shortness of breath. Your asthma, you won't be having as many exacerbations of asthma. Pregnancy, tied into that, you know. An increased risk of respiratory infections. And then realizing, you know, highlighting a benefit to them quitting, asking them to really think about what made it difficult for them, and then to remind them, you know, it takes people multiple quit attempts before they really are successful. And I'm here as a resource. So we're going to keep asking you these questions every time you come in. So it's going to be it's going to be part of the regular process. And tying them back into putting the resources in their hands and that you are a place where they can come to get this assistance and help. Next slide. And just for that extra level, you know, assisting them, if this is someone that, you know, has quit for a long time and they've relapsed, you know, we want to be able to do the same, provide the same resources to them. You know, hey, here's the resources to 802 Quit. Here's a tobacco treatment specialist. Do you want me to write a prescription for nicotine replacement? You know, you're helping them take that next step to being tobacco free. And relapse happens many times. How do we give them the support to make that relapse go into another quit attempt? And emphasizing, you know, the successes they've had in quitting in the past, that you know, recognize the issues they've encountered, and making sure that they're using that medication, that nicotine replacement properly. That's a huge one. All right. Next slide. And then A for arrange. What does the follow-up look like? And, you know, being able to tie it in that they receive whether a follow-up call or, you're monitoring the medication you prescribe them. Where does the follow-up occur? Is it at your clinic? Is it a tobacco cessation group? Is it a community health team? Or is it by phone? Being able to record that piece as well. Okay. And Karen Casper wants me to mention, too, that they're doing a specific healthier living workshop through myhealthyvt.org starting November 2nd that is going to have specific components to asthma self-management included in it. So if that's something that you're looking for resources, My Healthy VT, and it's going to be the Chronic Disease Self-Management course starting at 2 o'clock. I'm starting on November 2nd. So if you have patients you want to refer to that, I would definitely look into it. All right. Next slide, please. Are we going to do some case studies, or we're just moving along? So those are thank you guys. I will be here to support you. And if you have any questions or concerns, well, right now in the world, the past few months, I'm not doing direct tobacco cessation support. I will always be there to share my knowledge with you and reach out via email. And I'm, once again, more than happy to share anything I know to help build up your skill sets and for the success of our patients. Thank you.